Good morning, everybody. Thanks for being here. I'm really excited to share this information with you. I have been a staff doctor at Doctor's Data for about 12 years, and I've been practicing a functional medicine naturopathic doctor for the past 22 years. And in those years, I've seen a lot of change in patients. Seems that what we were trained to be prepared for then is very different from the norms that we run into in our practices now. Seems like chronic illness is at the top of the list of what brings patients in. And most are on at least one pharmaceutical medication. Many are on 2 and 3. As a staff physician and clinical educator for Doctor's Data, I've noticed how often I hear from providers who call us to talk about hormones or neurotransmitter results that their patient's health is suffering. And it's often a very sudden change with depression, anxiety, and sleep imbalances. I've been surprised at how infrequently the providers have given careful consideration to the impact that the medications are having on their patients' overall health. And I've noticed how often one medication seems to lead to another to manage the side effects of the first medication and so on, until these patients are stuck in a soup of medication, making it really hard to tease out what's driving the mental health imbalances. So I dove into the research to look closer to provide a foundation for the providers who test with us so that they can better help their patients, and also for my own practice so I can better educate my patients on the effects of pharmaceuticals that they're taking. So since I've seen so much change in mental health, it prompted me to look at what does history tell us about these trends. This timeline is offering a historical snapshot of how mental health has evolved in the US from nutrient psychiatry and institutional care in the 50s and 60s to pharmacological dominance in the 70s, and finally pharmacological dominance from the 70s to today, and finally, hopefully, to a more integrative view. You'll see how the prevalence rates of mood disorders and suicide trends have increased over time, paralleling the uptick in the reliance on medication. Fortunately, now, with the advent of functional medicine and functional psychiatry, we're starting to witness a renewed interest in the impact of nutrients and lifestyle on mental health. So we're going to go into all of this in more detail. The burden of mental health diagnoses and the use of medications has primarily fallen on women, as they're consistently more likely to be diagnosed with mood and anxiety disorders, and they're also more likely to be using medications than men. Nearly 26% of women aged 18 plus are reporting a mental illness each year, including depression, anxiety, and PTSD. Anxiety disorders are affecting about 23% of US women over the age of 18. Depression is seen in about 10 to 4% of women over 18. And women are twice as likely as men to be diagnosed with major depressive disorder. In 2020, 21% of women reported using medication for their mental health. So some sort of medication for mental health. So here we're looking at side-by-side comparisons of the prevalence of mental health disorders in both men and women. That men have lower reported prevalence, but keep in mind they're less likely to seek care. In men, mental health imbalance is more likely to show up as externalized symptoms such as anger or substance abuse. So what we're looking at here is about 18% mental illness in men versus 26% in women. Anxiety disorders about 14% in men versus 23% in women. Depression around 6% in men, about 10% in women. Major depressive lifetime risk for men is about 10%, whereas it's about 21% for women, so about 2x that of men. And medication use for mental health in general, about 11% for men and about 21% for women. So as I dug into the research on these trends, the impact of COVID on global rates of anxiety and depression just kept popping up, an estimated increase of 25% globally. That makes me wonder if it's playing a role in the stories that I'm hearing from the providers who test with us at Doctor's Data. Just after March 2020, right after the pandemic started, there was almost a 130% increase in antidepressant use in females aged 12 to 17, and a 56% increase in women across the board, 18 to 25. From 2016 to 22 in the US, there was a 66% antidepressant increase in 12 to 25-year-old females, whereas male rates decline. And sadly, in 2021, young men aged 15 to 24 saw an 8% increase in suicide rates over 2020. Women also bear the burden of cognitive impairment and dementia, while 12% of adults over 65 report subjective cognitive decline. Dementia is more prevalent in women, which is linked to advanced age, estrogen decline, genetics, and inflammation. 1 in 6 women over 65 will develop Alzheimer's, compared to 1 in 11 in men. Women represent 60% of all Alzheimer's cases in the US. Men account for about 34%. Alzheimer's, as the underlying cause of death, has increased by over 140% between 2000 and 2022, even as we've seen deaths from heart disease and stroke decline. So let's look at the nutrient impacts that we might see from medications. These are the top 5 most commonly used medications based on population studies. The percentage represents what percentage of men or women are using the medication. So statins, ACE inhibitors for blood pressure, antidepressants, and proton pump inhibitors for GERD top the list for both men and women. Men outpace women in statin use 30 versus 25%. ACE inhibitors, men 25% versus 21 in women. And beta blockers, 15 to 18% for men. They're less used by women, and you'll see that on the next slide. Women outpace men in antidepressant use and PPIs. With PPIs, it's about 14% for women, 10% for men. As mentioned, antidepressants are used about twice as much by women across all age demographics. Note for the purposes of this presentation, we're going to be talking about SSRIs. Whenever the word antidepressant is being used, we're mostly going to be talking about SSRIs because they're the class of antidepressants that are the most used across the board in men and women. And the most used medication for all women is progestin-based contraceptives and HRT. In the 15 and 18 age demographic, around 38.7% of young women are using a progestin-based contraceptive. In women in their 20s, 70 to 90%. Same for women in their 30s. Women in their 40s, 74.8%. And then for women in their 45 to 64, it goes down to about 5 to 10%. So as an overall kind of burden of progesterone-based HRT or contraceptives, when you're thinking about women in the 18 to 49 category, think about 80%. So we're going to spend a lot of time on this drug classification because its impacts go far beyond birth control and hormone replacement. And these are the references for that previous slide. This is a list of the next 5 most used, so numbers 6 through 10. I'm not going to spend as much time on these due to the interest of time, but I want to include this list because the statistics are still really impressive and to help you see the effects of polypharmacy. Because so many of our patients are taking these medications in combination with others on this list. So what we're looking at here, I mentioned the beta blockers in women. They're not using them to the same degree that men are, but they are using antihypertensives outside of the ACE inhibitors, 13 to 18% and that of women. And that beta blockers are in that category. Also calcium channel blockers, thiazide diuretics, and other vasodilators. And men are similar, about 13 to 16% beta blockers. 15% of women are on thyroid hormones. That statistic does not show up for men, although men are using diuretics, 10 to 14% of them are. 5 to 7% of women on benzodiazepines, about the same with men. Antihistamines, both over-the-counter and prescribed, are about 10 to 13% in women, a little bit lower in men, 8 to 10%. And opioid use is really on the decline, about 5 to 6% of women and about 3 to 5% in men. So here we're looking at polypharmacy statistics, meaning the use of more than one medication. I wanted to include this to highlight how depletion impacts or increases with the more medication that one takes. So with one medication, and the left here, you're looking at women statistics, and on the right, men. With one medication, about 70% of men and women are on one. So we're looking at a single medication nutrient impact. But as soon as one is on 2 medications, and that's 40 to 45% of the population, we're looking at increased risk of multiple deficiencies. 3 medications, 20 to 25% of the population, a significant cumulative depletion. 4 medications, 10 to 15% of the population, high risk of nutrient depletion. And 5 or more medications, 40 to 79 age category, 21 to 23% of the population is on 5 or more medications. So here we're looking at severe nutrient depletion risk and complex interactions. And note that even in the 18 to 40 age demographic, about 5 to 8% of the population is on 5+ medications. In the next 2 slides, I'm going to give you a survey of the mechanisms that cause the depletion for each of the top 5 medications, along with the mitochondrial impact, just to set the stage for more in-depth exploration for each of the top 5 to come. So this presentation is mostly focused on women since they have the higher rates of medication use, but it all can be extrapolated to men because iatrogenic nutrient depletion is not gender specific. As mentioned, we're going to spend most of our time on the top 5, but I'm also providing the honorable mentions for you in the next slide for your review. So with antidepressants, specifically SSRIs, the most shocking information I uncovered in my research that we'll delve into more detail later was related to SSRIs, and it is this. Outside of the impact that they have on serotonin, SSRIs have broad spectrum antimicrobial activity similar to antibiotics that alter gut microbiota composition and increase oxidative stress. So if you just fell out of your chair, like I did the first time I read this, get back in your chair and fasten your seatbelt. This raises the demand for dysbiosis that comes from this broad spectrum antimicrobial activity of SSRIs, raises demand for B vitamins. It also impairs CoQ10 status, which is going to impact mitochondrial ATP synthesis. So while SSRIs don't directly deplete nutrients, the combination of the gut dysbiosis and the increased demand for nutrients to fuel the perpetual liver metabolism that is involved with detoxifying the medication contributes to functional depletion over time. And this functional depletion over time is a common theme that you're going to be hearing a lot more about. Statins, in the process of decreasing cholesterol biosynthesis, statins inhibit HMG-CoA reductase, which is the key enzyme that synthesizes both cholesterol and CoQ10. This reduction in CoQ10 production directly impairs mitochondrial function by disrupting the electron transport chain's ability to produce ATP, contributing to fatigue, especially in energy-demanding tissues like muscle, heart, and brain. Proton pump inhibitors, PPIs, raise gastric pH, meaning that acidity or HCl becomes depleted, and long-term use of PPIs, which is considered 12 plus weeks, leads to impaired solubilization of minerals, and it reduces intrinsic factor. So this is going to impact absorption of key micronutrients, magnesium, B12, iron, and zinc, impacting ATP production and methylation. ACE inhibitors lower blood pressure by reducing angiotensin II and aldosterone, which alters how the kidneys are going to handle electrolytes, leading to sodium loss and potassium retention and potential disruptions in magnesium and zinc levels. They can also contribute to decreased CoQ10 transport, especially in patients that are using statins. That's going to impact that CoQ10 transport, which increases oxidative stress in the mitochondria, decreasing ATP production. And then for progestin-based contraceptives and HRT, they're going to increase liver metabolism, which uses up B6, B12, folate, magnesium, selenium, and zinc, impairing mitochondrial enzyme function, neurotransmitter synthesis, and DNA repair. And this is the honorable mention list that I mentioned, 6 through 10. Change this one around just a little bit. I wanted to add NSAIDs because of how frequently they're used. They weren't on the top 5 or the top 10 list, but because they're so frequently used among men and women, I wanted to include them because of the impact that they have on gut mucosal integrity and the impact for impairing absorption. So I just wanted you to see that many of the same mechanisms are at play here in terms of decreases in CoQ10, magnesium, potassium, B6, B12, and iron, all nutrients that are important for methylation, ATP production, and neurotransmitter production. Be especially wary of polypharmacy with our senior population. There's new research out of Ireland that was in adults 65 plus, about 500,000 people. They found what they described as prescribing cascades, meaning that drug side effects often went unrecognized and were presumed to be a new illness. And this triggered additional prescriptions to address the new symptoms. So the cascades that they uncovered were benzodiazepine use led to antipsychotic use, calcium channel blocker use led to diuretic, SSRIs and SNRIs led to sleep medication, alpha-1 receptor blockers for prostate led to vestibular sedatives, and antipsychotics led to anti-Parkinsonian agents. As well, in the lower half of the slide, you're seeing a retrospective cohort study, the US Medicare data, in 65 plus adults when they were hospitalized or they had an inpatient stay in a nursing home or rehabilitation center. 5% while they're inpatient stays are prescribed a new sedative or an anticholinergic medication. So that addition of the second medication is associated with a 60% higher odds of post-discharge fall-related injuries. This will probably ring true for a lot of you who are dealing with parents who are seniors and patients in your practice, or even the parents of your patients who are caregivers. So we're going to spend quite a lot of time on the mechanism of depletion relative to progestin-based contraceptives and HRT because of that prevalence in women. Remember, in the 80 to 49 demographic, about 80% of women are using a progestin-based contraceptive or HRT. This chart is showing you how they compare to other hormones. On the upper left here, we're looking at synthetic progestins in birth control pills, IUDs, and implants like the Norplant vaginal ring, injections, and emergency contraception. It should also say HRT here. And the nutrient depletion risk from these is high because of the perpetual hepatic metabolism required to detox the medication, leading to oxidative stress and micronutrient turnover. For the conjugated equine estrogens or progesterone, which is oral, there's a moderate nutrient depletion risk because of the first pass hepatic metabolism and increased B6 turnover and inflammation, not quite as high as the progestins. Bioidentical progesterone, there's a low nutrient depletion risk because there's minimal hepatic metabolism, even when it's oral progesterone. And for transdermal estrogen, there's a very low nutrient depletion risk because it bypasses the liver and there's very minimal systemic depletion. We're going to walk through each of the top 5 medications in more detail. So let me just give you a quick tour of how the slides are set up. On the left is documented evidence of the medications depleting certain nutrients. In the middle, we're looking at how those depletions have been shown to impact mental health. And on the right, I included any mental health conditions that are associated with that specific medication. So this category of medications, progestin-based contraceptives and HRT, is one of the most impactful across the board because of the prevalence of youths and because of the young age at which many girls will start using birth control when their brain is still developing until about the age of 25. Unrelated to contraception, they're being prescribed usually birth control pills to manage symptoms associated with menarche, such as irregular periods, acne, and excessive bleeding, and potentially far-reaching effects in terms of their mental wellness, especially when you consider how many women may also be placed on an SSRI for mood management and or other nutrient-depleting medications for reflux, high cholesterol, blood pressure, all the things that we see in our practices. So let's zoom in on a few of these key nutrients: B6, B12, folate, magnesium, and zinc, the ones that are the most consistently depleted. These are the nutrients that are essential for neurotransmitter synthesis, circadian rhythm, and methylation. So when they're low from chronic progestin use, we may see more mood lability, anxiety, fatigue, and even treatment-resistant depression. We also see effects related to vitamin C and E and selenium contributing to oxidative stress, neuroinflammation, and poor resilience to stressors. I grade them out a little bit just because the data is not quite as rigorous, but I felt that it was worthy of mention as this is developing research. And these depletions don't just affect brain chemistry, they also interfere with detoxification. Progestins are metabolized primarily through phase 1 liver detoxification using cytochrome P450 enzymes. However, it's the phase 2 pathways, methylation and glucuronidation, that are critical for clearing the hormone metabolites. But wait, you might be saying, what about other modes of delivery like the Mirena, the implant, the vaginal ring? How are they contributing to phase 1 liver detoxification, even though they're not delivered orally? That's a great question. And the answer is yes, they are still contributing to phase 1 liver detoxification, just less so than the oral products. Because the progestin is synthetic and not bioidentical, like any medication, it needs to be detoxified through the liver. And over months and years, this constant demand depletes the pool of available nutrients. So when methylation becomes compromised, these metabolites accumulate and they can result in symptoms like mood swings, depression, anxiety, sleep problems, and fatigue, all the conditions that you're seeing here in far right column, or even increased systemic inflammation, which alone can drive all these processes. So it becomes particularly important as we transition into the section on testing, because we're going to look at neurotransmitter panels and methylation profiles so that we can look at these patterns clinically. These are large studies out of Denmark and Sweden in women, but what they really showed was that adolescent girls in the 15 to 19 demographic have a 2.2-fold higher risk of depression diagnosis after they start hormonal contraception. In the broader 15 to 34 age group, this risk is also present. It's a little bit lower at 1.8 times, but still significant over non-users. The studies also found significantly higher use of psychotropic medications, including antidepressant and anxiolytic, in the adolescent contraceptive user population, raising the question, are we medicating symptoms caused by the contraceptives themselves? This was a follow-up study to the Danish study using the original data. It included first-time mothers who had no diagnosis of depression in the 2 years before birth. In the new mothers, those who had a history of depression that was associated with prior hormonal contraception use had a higher risk of postpartum depression. They even compared them to women who also had a history of depression, but it wasn't associated with hormonal contraception. And that's what you're seeing here in the yellow bars. The women with the history of depression that was associated with contraception use had the highest risk of postpartum depression. The risk was regardless of timing of the initiation of contraception, either in adolescence or adulthood. As well, the researchers noted that after giving birth, mothers who initiated hormonal contraception within 12 months had a 49% higher risk of developing depression versus mothers who didn't initiate hormonal contraception. On that note, I wanted to share some promising news that appeared recently in the midst of my research. A Berlin-based startup received regulatory approval in the UK and the EU for a saliva-based contraceptive device called MiniLab that measures progesterone levels daily to prevent pregnancy. In a 12-month study of over 300 women, the device was 100% effective with perfect use and 92% effective with typical use, very comparable to a birth control pill and superior to condoms. So this to me is really hopeful as a non-invasive, hormone-free option. It's still got to work out some of its kinks, but it is available in Germany and Austria, and the UK plans to launch it later in 2025. And it's offered via subscription for about 24 euros per month. So let's look at SSRIs, which many contraceptive users end up on, often without anyone asking whether nutrient depletion or hormone-induced symptoms are at the root of the depression in the first place. SSRIs are among the most prescribed medication in women, from 10 to 25%. And while they can be life-saving, especially with early use, they are not without consequence, particularly from a nutrient and mitochondrial perspective. So first we see the depletion of B12, folate, and CoQ10. Low levels of these are directly associated with fatigue, apathy, poor antidepressant response, and even cognitive decline. In older adults, SSRIs have also been shown to reduce sodium levels, leading to fatigue, confusion, and in some cases, it worsens their depressive symptoms, which is especially important with postmenopausal women or those on polypharmacy who are using medications. Note in the right-hand column, these conditions are all associated with SSRI use: depression, anxiety and agitation, suicidal ideation or behavior, emotional blunting or apathy, sleep disturbances, fatigue or sedation, and sexual dysfunction. So if your SSRI patients are experiencing any of these symptoms, it's really important to question the possibility that their use of the medication is playing a role. I mentioned earlier about SSRIs having a broad spectrum antimicrobial effect. We're going to get into that mechanism. Why is that? It's due to their positively charged lipophilic nature, enabling them to prevent reuptake, but it also enables them to disrupt membrane activity, minimizing integrity and causing leakage of cellular contents. So we see a cycle of microbial disruption similar to antibiotics: dysbiosis, oxidative stress, impaired absorption of magnesium, zinc, B vitamins, and folate in the small intestine. This is ultimately going to impact methylation, neurotransmitter synthesis, and mitochondrial function. Clinically, this means that even if the SSRIs help mood symptoms in the short term, they may be contributing to impaired gut function and perhaps long-term fatigue, apathy, or treatment resistance in the long run. So that gut-brain connection is really being impacted here. Proton pump inhibitors are often taken long-term at only 12 weeks of use, which is considered long-term use. They've been shown to impact nutrient absorption by raising stomach pH and reducing acid, which decreases the solubilization of key micronutrients B12, magnesium, iron, and zinc. Low HCl is also going to contribute to decreased intestinal absorption, which is going to impact methylation, mitochondrial ATP synthesis, and antioxidant defense. Clinically, PPIs are associated with depression, anxiety, suicidal ideation, and cognitive decline. So even though PPIs seem benign, over time they can create a low-grade, functionally depleted state that worsen fatigue, apathy, and mental performance, especially in those patients that are already on other medications or with poor diets. So again, here, think polypharmacy, because 10 to 15% of the population is taking these medications. As I mentioned briefly earlier, statins lower cholesterol by inhibiting the enzyme HMG-CoA reductase in cells to prevent cholesterol synthesis. And it's mostly a hepatic effect because of first-pass metabolism. And the liver is where most of cholesterol is being produced. That this mechanism also has systemic effects because it takes place in other tissues, especially in high demand tissues, such as skeletal, cardiac, and brain. So while you're reducing cholesterol production with HMG-CoA reductase, you're also reducing CoQ10 production, which is essential for ATP production. So that's one reason that fatigue and muscle symptoms are among the most common patient complaints from statins, and especially in energy-demanding tissues like the brain, heart, and muscles. Statins can also impair the absorption of metabolism of vitamin D and selenium, contributing further to mood-related symptoms such as low energy, irritability, and even seasonal affective disorder. So to be clear here, though, the majority of these high-quality studies don't show a consistent increase in depression or cognitive decline with statin use. And even some of the research has suggested a neutral or protective effect. But clinically, mitochondrial-related symptoms are reported associated with statins, such as fatigue, muscle weakness, and sleep changes, likely related to the mechanism of low CoQ10, contributing to low ATP output. And this may be more pronounced in patients with existing nutrient insufficiencies and those on polypharmacy. So the mental effects here are likely reflecting the nutrient depletion and the mitochondrial disruption and not direct neurochemical effects of the drug itself. Angiotensin converting enzyme inhibitors, or ACE inhibitors, block the conversion of angiotensin 1 to angiotensin 2, which is a vasoconstrictor. So it results in dilation and reduced vascular tone, and it lowers aldosterone levels, all of which is going to contribute to reduced blood pressure. However, this mechanism also leads to electrolyte imbalance, sodium loss, potassium retention, and the potential for more disruptions in magnesium and zinc levels. And while the ACE inhibitors don't directly act on CoQ10, they can exacerbate CoQ transport disruption in patients that are on multiple medications or with underlying heart or kidney conditions, reducing the electron transport chain's ability to produce ATP, again, impacting mitochondrial energy production. So zinc depletion is linked to symptoms like apathy, low motivation, and anhedonia. With magnesium deficiency, we're going to see more risk for anxiety, insomnia, and reduced stress resilience. It's important to note that while symptoms like fatigue, cognitive changes, depression, and sleep disruption are often associated with ACE inhibitor use, the mechanism is also more likely nutrient related rather than a direct pharmacologic effect on the nervous system. I recently listened to a podcast interview with a psychiatrist named Dr. Chris Palmer that was groundbreaking for me in that it shifted the way that I look at mental imbalance. His approach to mental health is based on the premise that mental disorders are metabolic disorders of the brain that are rooted in mitochondrial dysfunction, which he refers to as mitochondrial metabolic disease. He wrote a book called Brain Energy in 2022. So this is an overview of what we've been discussing, how depletion leads to oxidative stress and dysfunctional mitochondria, leading to decreased ATP production and more oxidative stress and inflammation, and ultimately mitochondrial damage, which is going to impair methylation, neurotransmitter synthesis. So this is the central premise of his book. When mitochondria are undernourished or impaired, brain function suffers. Supporting mitochondrial health is foundational to restoring mental wellness. And interestingly, there are well-supported associations between mitochondrial dysfunction and depression, bipolar disorder, schizophrenia, autism spectrum disorders, and even Alzheimer's and Parkinson's. And there are emerging links that are linking mitochondrial dysfunction to anxiety disorders, OCD, ADHD, PTSD, and eating disorders. This research paper from 2016 outlines the role that nutrients play in protecting the mitochondria and neurotransmitters from the stress of high cortisol and glutamate. So if you start with the green boxes here, the essential nutrients like folate, B12, magnesium, zinc, vitamin C, and omega-3s, they're shown feeding into different parts of the neuron to protect against damage and support function. The blue ovals here are the mitochondria, where ATP is produced and oxidative stress is regulated for neurosignaling. And in the white triangles, we're looking at homocysteine, oxidative stress, and decreased lipids, representing dysfunctional states that are triggered by nutrient depletion and stress. Elevated homocysteine, for example, can trigger calcium overload, oxidative stress, and mitochondrial damage, all of which impair neuron survival and its signaling. The good news being that when we're replete in the nutrients in green, the protection is taking place. And I just made this quick little chart for your review, going through all the different nutrients and what their specific role is in mitochondrial function. So now that we've walked through how the nutrient depletion disrupts mitochondrial function and downstream brain signaling, let's flip the script because there's good news too. And that is that nutrient repletion can help reverse this trajectory. Multiple studies have shown that restoring depleted nutrients like magnesium, B vitamins, omega-3, zinc, others, the same list over and over again, can directly improve symptoms of depression, bipolar disorder, schizophrenia, and anxiety. It's not theory, it's evidence-based support for mitochondrial restoration as a therapeutic strategy. So think of it this way. If nutrient depletion contributes to oxidative stress, impaired ATP production, faulty neurotransmitter signaling, then repletion can stabilize these systems as we saw in the slide of the cell, enhancing neuroplasticity, reducing inflammation, and ultimately rebalancing mood chemistry. So this is for your reference. Also, I'm not going to walk you through it because we're not spending a whole lot of time on treatment, but I wanted to point out the nutrients here: depression, methylfolate, B12 plus folate, magnesium, zinc, and SAMe have all been shown to improve depression. For bipolar disorder, omega-3s and NAC have been shown effective. For schizophrenia, NAC, glycine, folate plus B12 have all been shown effective. And for anxiety, magnesium and L-theanine. All right, so testing. This is where the rubber meets the road. We have some great tests at Doctor's Data to help you identify weaknesses contributing to your patient's poor health. This is the neurotransmitter pathway chart that looks very overwhelming at first glance, but it's one of the most valuable tools to help you understand how nutrient depletion can affect neurotransmitter balance. And I recommend that you have it open while you're going over your patient's neurotransmitter results, which we're going to be looking at in the next slide. Every major pathway that you see here requires nutrient cofactors, and that's what in red. What I want you to notice is how the same nutrients show up over and over again across multiple pathways, and they're the same nutrients depleted by medications. So here in this key in the bottom right-hand corner, you see BH4, which is tetrahydrobiopterin, and this is produced endogenously with the support of SAMe, the universal methyl donor, and then SAMe is supported by MTHF, methylfolate. But you're going to see that BH4 at the beginning of serotonin and dopamine pathways. Anytime you see BH4, you know that methylation is involved. Also, the methyl donor SAMe is required for the final conversion to melatonin, epinephrine, metabolite, and the serine glycine pathway. So all requiring methylation because SAMe is supported by methyl tetrahydrofolate. This is our neurobasic profile, just basic neurotransmitters without metabolites. We're going to look at metabolites in the next slide. This was in a patient of mine, a 15-year-old on an SSRI and on a progestin-based contraceptive implant, so a Norplant. Keep in mind, this is our most vulnerable group. The brain's still developing. They don't have the best nutritional practices. They're not sleeping well. And here you see that the serotonin, it's within range. The green zone here is the optimal range. You can see that the serotonin is within range, but it's not hardy. I'm not going to call it low, but I'm not going to call it hardy. So it makes me wonder, is the SSRI increasing serotonin from a much lower level, meaning it would have been much lower if she hadn't been on it? Or if over time, due to gut dysbiosis and oxidative stress, did it decrease serotonin from where it might have been at a much higher level, either not on an SSRI or when the patient initially started SSRI? So when I see low and low range monoamines, serotonin, dopamine, norepinephrine, and epinephrine, I wonder if the methylation machinery is malfunctioning because methylation is required for all of these conversions. Later, we'll see how methylation enables us to look under the methylation profile itself, enables us to look under the hood to see how those neurotransmitters are being made, recycled, and cleared. This is the comprehensive neurotransmitter profile that gives us a bigger picture because we're looking at neurotransmitters and their metabolites. So for example, we're looking at dopamine and DOPAC, serotonin and 5-HIAA, norepinephrine and norepinephrine, et cetera. When methylation is sluggish, whether from nutrient depletion or genetic SNPs, you might see low downstream metabolites, or you might see buildup of parent neurotransmitters. If a patient has a fast COMT or MAO activity, we may see low parent neurotransmitters with relatively high metabolites, suggesting rapid clearance. On the other hand, with slow SNPs, often seen with MTHR and COMT variants, the patient may present with normal or high neurotransmitters, but sluggish metabolic output, indicating poor clearance and potential buildup that can lead to mood instability and other symptoms. So this test gives us a window into whether the methylation machinery is functioning, and it previews what we're going to explore in more detail with the DNA methylation profile. We have a wonderful guide on the website in the materials and resources section that supports treatment decisions based on whether neurotransmitter results are low or high. Note that the guide makes suggestions of how to support high levels by supporting metabolism and conversion, and how to support low levels with nutrient cofactors. The guide addresses each one of the neurotransmitters in our profile, and this is just a sample of page 1 here, looking at serotonin, GABA, dopamine, and norepinephrine. But the rest of the guide covers the rest of the neurotransmitters. So this is a diagram of of phase 1 of the methylation cycle, or the upstream portion where methionine is converted to SAM, our primary methyl donor. SAM is going to donate methyl groups for vital processes like neurotransmitter synthesis, gene expression, and membrane formation. After SAM donates its methyl group via methyltransferase, MTAs here, SAM becomes SA, or S-adenyl homocysteine, which then converts into homocysteine. At this point, homocysteine is a crossroads metabolite because it can either be remethylated back to methionine, requiring B12 folate and magnesium and zinc, or it can enter the transsulfuration pathway shown at the bottom of the diagram here, where it's going to convert into cystathione and then to cysteine, which is the precursor to glutathione, our most important antioxidant. So glutathione is not shown here, but just know that it is the next step downstream, and its synthesis relies heavily on nutrient status, in particular B6, magnesium, and zinc. So in summary, this cycle impacts everything from methylation and neurotransmitter production to phase 2 liver detoxification and antioxidant defense. So you can see how the nutrient depletion can bottleneck this process at several different points. And this is our methylation profile. It's a plasma test. Here we're looking at 2 things, and you're asking like 2 main questions about results. 1, are the nutrient-dependent metabolites in range? And is the SAM-SAW ratio healthy? So here we're looking at methionine, it's mid-range. So substrate is available, but SAM is low, suggesting that there's poor conversion from methionine to the body's key methyl donor. SAW is elevated, and that's significant because SAW inhibits methylation reactions, as we saw in the slide here. If SAM is being bypassed in favor of SAW, then these methylation reactions aren't going to be taking place. The SAM-SAW ratio here is just 2.2. We really want to see it above 4. And so that tells us that overall methylation is impaired. Homocysteine is high normal, possibly reflecting sluggish remethylation or low cofactors such as B12, folate, magnesium, or zinc. And cystathione is low normal. And while cysteine is adequate, a bottleneck in the transsulfuration pathway could impact downstream glutathione production. And this is our DNA methylation profile, which is a buccal swab evaluating key genetic SNPs, especially those that govern how well we produce and recycle methyl groups. So that includes well-known genes like MTHFR, MTR, MTRR, and BHMT, which affect how efficiently we convert folate and B12 into usable forms like methylfolate and methylcobalamin. SNPs can create bottlenecks in the methylation cycle, impacting neurotransmitter balance, detoxification, and resilience to stress. What's helpful is that this test also includes COMT and MAOA that are necessary to break down neurotransmitter metabolism. They break down dopamine and serotonin, and very quickly or slowly, however they do that, quickly or slowly, is genetically influenced. So if we see that somebody has a slow COMT or an MAOA, they may hold on to cholestyramines longer, which can increase reactivity or anxiety. Or if somebody has a fast variant, they might clear those neurotransmitters too quickly, leading to a low mood or a blunted effect or thrill-seeking behaviors. So this test really bridges the methylation capacity that we saw in the previous test and neurotransmitter balance. So this is side-by-side comparisons of the 3 tests that we just reviewed. I'm going to start at the bottom here with the DNA methylation buccal swab and work up. With the DNA methylation test, we're looking at genetic predispositions, so SNPs, including MTHFR, COMT, and others that are involving methylation. These results are not going to change over time. So it's going to give information about lifelong vulnerabilities. For example, someone with a homozygous MTHFR mutation may be more sensitive to folate depleting medications, such as oral contraceptives, and they may require lifelong methylated folate support. Second, in the middle here, the methylation profile reflects real-time function. It helps us see how methylation is performing under current conditions and gives us an indication of nutrient status, stress, and medication load. And if you see that low SAM, high SAH, or that lower SAM-SAW ratio, which may be due to nutrient depletion, and this is excellent for monitoring interventions and response over time. So you'll definitely see that methylation profile change with treatment. And finally, the neurotransmitter profile, either the neurobasic or the comprehensive, gives a snapshot of neurotransmitter output. And while this isn't a direct methylation test, it helps us see the functional consequences of poor methylation or nutrient depletion. So finally, notice the medication depletion relevance column. This is where we start tying all 3 tests together. So a medication might not affect a SNP directly, but it could deplete a nutrient required by that pathway, or it could create an imbalance that shows up downstream in neurotransmitter pathways. So we hope that this integrative approach will help you in your practice, not only to identify biochemical vulnerabilities, but also to enable you to respond with targeted evidence-based support.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.